is unable to attend today, so I'm filling in for him. If you don't know who I am, I'm Janos Hayagush. I am a faculty member in the Department of Biomedical Informatics at Stony Brook. So welcome to the N3C Community Forum. Next slide. Okay, so a couple of, I know a lot of people have been on this already, so these are some reviews for everybody that's here. The presentation will be recorded and will be archived in the CD2H YouTube channel. And then please use the Q&A button to post your questions. Use the raise hand feature for the host to unmute your microphone. And then for anything else, please post in the chat section. So those are just some general rules. And so, yes, it's coming to the end of the calendar year. So, this is, and we still have another set of 3 exciting talks coming up for the end of this calendar year. And just as a start for next week, because it's a Thanksgiving holiday week, we will not have the community forum, but it will begin again on November 28th, and we'll hear about HIV, COVID, and SDOH. And this is an area that N3C has been sort of a pioneer on, sort of integrating SDOH data. And then on December 5th, we'll have on musculoskeletal-associated post-acute sequelae of SARS-CoV-2. And then on December 12th, we'll have malnutrition and COVID-19 outcomes. And next, okay. Yeah, so this is always, I've been involved with the N3C since the early days of it starting, and it's always still impressive to see the site growing. We have, and even though we're not adding as many sites as we did in the earlier days of the project, the rate still is still a positive rate. So we keep adding sites. So now we're up to 76 sites, and I know there's potentially another couple ones might be coming on in the coming months. So that number might get higher. But right now we have just about 20 billion rows of data representing 16.4 million anonymized persons, still the largest, COVID repository. And there's 6.4 million COVID positive cases, large number of clinical observations, 9.5, almost 10 billion lab results, 3 billion medication records. So, it's a very rich, deep data set, and the many talented teams working on this project keep advancing the science of COVID. Next slide. Okay, so today's talk, and this is always as we learned from the beginning was COVID, right? That it's not just a single, it's not just respiratory, right? But it's a complicated illness, and so there's definitely different outcomes and different effects on multiple diseases. So today we have a talk on the impact of COVID-19 on clinical outcomes among acute myocardial infarction patients undergoing early invasive treatment strategy. And our speaker today, and I hope I get the name right, and I know people, I have empathy for names because my own name gets mispronounced, but we have Dr. Sula Mazimba from University of Virginia speaking today. And I know for all of us, our thoughts for University of Virginia go out what's happened on the campus in the last day or two. So if Dr. Sula Mazimba, you want to start? Are you ready?
Yeah, thank you. Thank you so much for that production. I like to share my slides. I don't know whether you can see my slides.
Yes, we can.
We can see them.
So, certainly over the last few hours, it's been very challenging here at UVA. We are mourning loss of three students. As you all know, the shooting that occurred, really very tragic circumstances. And if you may, I would like to just maybe see if we could just give a moment of silence for those that have that we've lost as we mourn during these terrible times at UVA. So thank you again for the privilege to be able to share some of our work regarding COVID and outcomes in patients with acute myocardial infarction, and especially specifically looking at patients undergoing early invasive treatment strategy. The the problem that we sought to really interrogate was really the implication of COVID-19 infection status on the outcomes after invasive therapeutic strategies in acute myocardial infarction. And our data did demonstrate, just sort of as a bird's eye view, that there are differences in outcomes and there are deleterious effects amongst patients who have COVID-19. As you all know, hospitalized patients with COVID-19 have adverse outcomes. They have about 10 to 30% increased risk of myocardial injury, with higher rates in patients who have severe cases of COVID infection. And the cardiac complications could be attributable to several mechanisms that have been postulated, including activation of inflammatory cells within atherosclerotic plaques and the generation of prothrombotic state as a result of COVID, leading to coronary thrombosis. And thirdly, increase in metabolic demands from an activated immune system. Those are some of the sort of proposals, hypotheses that have been proposed regarding the heightened increased risk of cardiovascular complications in COVID patients. It is known that early invasive strategy in patients who present with acute myocardial infarction is associated with improved outcomes. And so this is why we wanted to sort of really interrogate COVID infection with acute myocardial infarction. And with regards to MI, the most common pathway following an invasive diagnostic coronary angiogram is either a percutaneous intervention of the culprit vessel, or patients may have a non-revascularizable anatomy or coronary artery disease, and therefore surgical revascularization is recommended. And so patients may end up going to coronary artery bypass grafting. And then you may have a combination of surgical revascularization and percutaneous revascularization. And in other cases, we have medical management. So those are some of the treatment strategies after an invasive coronary angiography. And so we wanted to look at the implications of COVID infection status on the outcomes after therapeutic strategies that I've just highlighted here. And so our study design was a cross-sectional design, a retrospective analysis of the National COVID Cohort Collaborative Database. At the time, there were 50 institutions that had contributed data to the N3C, spanning from January 1, 2018 through April 10, 2021. And the demographics were administratively reported. AMI events in the N3C datasets spanned 2 years prior to the onset of the COVID pandemic, but we did not necessarily include patients, as I will discuss, pre-COVID who had MI. And so SARS-CoV-2 diagnostics were still in development in the early part of 2020. And so the patients that we included from March 15, 2020, by that time we had the diagnostic code that we could use for this analysis. And all patients in the study cohort had a SARS-CoV-2 positive PCR or antigen lab test positive as to be regarded as COVID positive. And then, of course, we also looked at those who had COVID negative tests. And no other patients were considered basically COVID negative if they did not have COVID-19 positive test. So we we included patients who had a diagnostic, a COVID positive diagnosis within the 3 months prior to the MI or within 2 days of the MI. And all patients with ST elevation MI or non-ST elevation MI were included. And we, the patients who had underwent an early invasive strategy within 72 hours of diagnosis of MI were included in, made the inclusion criteria. Then we stratified COVID-19 positive MI patients into 4 groups based on the treatment strategies. The 4 groups being coronary angiogram with PCI within 3 days of MI, and without cabbage within the 30 days of MI, or with cabbage within the first 30 days. And then the treatment group 2, which had subgroups, were coronary angiogram without PCI within 3 days of MI. And in this category, we had patients who had bypass surgery within 30 days following MI with neither PCI or cabbage. And then the last group was patients who had coronary artery bypass within 30 days. So the groups of relevant medical codes were identified using the observational medical outcomes partnership or common data model. And these groups of medical codes or concepts were created to identify COVID-19 diagnosis and comorbid conditions as well. And we used propensity matching, and data sets were stratified into the 4 groups based on the treatment received for each. And for each strata, the propensity score for COVID-19 positivity was calculated via logistic regression with independent variables, including demographics, such as age, sex, race, and ethnicity. COVID-19 positive patients were matched to COVID-19 negative in a 1:3 ratio using a caliper of 0.2. And only AMI patients after March 15, 2020 were included in the study to ensure adequate comparisons between the 2 groups. We had initially tried to look at controls before the COVID pandemic, but we discovered that there were a lot of therapeutic variations between the 2 eras. And so we decided to use the COVID-19 negative patients as sort of controls. And the outcomes that we looked at were reported death, respiratory failure within 30 days of the MI, cardiogenic shock within the first 2 days of the MI, pre-hospitalization within 30 days of the MI, and then prolonged length of stay. And then much data sets were used to identify differences in the outcomes between COVID-19 patients, positive and negative patients. So from a statistical analysis standpoint, COVID-19 positivity was regarded as a binary indicator of whether the patient had SARS-CoV based on the test, on the PCR or antigen lab test, like I mentioned, within the last 3 months or up to 2 days after the AMI event. And conditional logistic regression was used to model the binary outcomes. And outcome modeling was also done separately for each treatment group. We used the Bonferroni adjustment for multiple comparisons, and we used our statistical software. And from the results standpoint, we had At the time, about 1 million patients in the N3C dataset, and out of those, 80,000 patients had reported to have MI diagnosis. And after several exclusions based on pre-specified inclusion criteria, we had about 10,500 patients at MI. And out of those, you can see the treatment strategies that we had. The PCI group had 3,700 patients. PCI with bypass 1,400 patients, and neither PCI nor cabbage about 3,800 patients, and the cabbage patients about 1,400 patients. And of these, of the 10,000 patients, 5% had COVID positivity. Of the COVID-19 patients, 16% were non-Hispanic, African-American patients, and 11% were Hispanic or Latino, and 67% of the patients were non-Hispanic white patients. And as you could see from the data here on this graph, the odds ratio of respiratory events was high in the COVID positive patients. The death rate was similar, as well as cardiogenic shock, but what we found was length of stay and respiratory failure were higher in patients who had COVID-19. And this is a graph here showing the Bonferroni adjusted ratios. As you could see, patients who had mortality was similar in the treatment groups. There were a few numbers in the PCI, but the p-value was non-significant. And then with respect to respiratory failure, as you would expect, COVID patients had higher respiratory failure. And respiratory failure in this case was defined as being on the vent or ECMO or requiring mechanical respiratory support of some sort. And then when you look at length of stay, the length of stay was significantly higher in patients who had COVID, as well as in patients who had coronary artery bypass grafting. So what is the summary of our findings? The interpretation of our results indicate that patients with COVID-19 infection undergoing early invasive strategy for MI had a higher rate of adverse events than those without COVID-19 infection, and more specifically, respiratory failure and length of stay. And so from this large cohort of AMI patients with COVID-19 positive status, we see differences in outcomes driven in part by adverse respiratory events and increased utilization of healthcare resources. The challenges that we faced were the real world effects of medical data using some, as many of you would deal with the N3C harmonization of the data across the contributing sites has obviously been one of the challenges. The N3C data selection pipeline and informatics limitations pertaining to computation processes regarding this large data set was obviously a major challenge. And then, of course, there were discrepancies in data due to inconsistency in some codes across multiple sites, which our informatic teams had to work through. Overall, AMI admissions and interventions in our cohort were certainly impacted by the pandemic, and so there were treatment variations across sites. So those were the main sort of challenges that we encountered. So nonetheless, our data does demonstrate the differences in outcomes and among patients who have COVID-19 infection presenting with AMI. And these data certainly demonstrate that COVID-19 positive patients with MI undergoing early invasive coronary angiography had worse outcomes than COVID-19 negative patients. And the prolonged length of stay among COVID-19 patients was certainly contributing factor to the differences that we noted. And we certainly think that the COVID-19 is a respiratory virus, and therefore the respiratory failure was certainly not surprising to see that's where we found the differences in outcomes. And I'd just like to acknowledge my colleagues who were instrumental in in this work, and also the N3C data enclave, the iThrive CS, the iThrive informatics that helped with the analysis, and of course the participating hospitals and patients, as well as the N3C core teams and consortial authors that contributed to this work. And thank you for listening, and I would certainly be happy to answer questions about our work.
Okay, so I don't know if you can you see the Q&A, or you want me to read it? So there's I'll read the question if you can hear me. I know we had some audio issues. Thank you. This is from David Sanner. Thank you for this excellent talk. Any thoughts on the reason why respiratory failure and lengths of stay findings were limited to certain revascularization groups? In particular, it is counterintuitive that enhanced risk of respiratory failure would be seen in PCI patients, but not those undergoing CABG or PCI and CABG. I think that is what the slide with the adjusted p-values showed.
I'm so sorry, I'd lost you for a second. Are you able to repeat the question?
Maybe can you see the Q&A? It's in the Q&A. I can, if you click on the bottom, you can see the Q&A. I can read it. I can read it again. Okay, so any thoughts on the reason why respiratory failure and lengths of stay findings were limited to certain revascularization group? That's the first part of the question.
I see. Well, we thought that perhaps among these patients, that's where you have a bit of difference, because if you have COVID and have MI and you have a PCI, if when you compare the COVID negative patients versus the COVID positive patient, the length of stay tends to be lower for patients who have PCI. Within a day, they are discharged. But if you have COVID and if you discharged after 5 days, you'll probably be able to see the difference there versus perhaps patients who have, who did not have PCI. Perhaps the length of stay may be not as high. So that's my sort of thinking about this. But again, it's always hard to really make a lot of meaningful data from a retrospective study without knowing exactly. We're looking at administrative data.
And if you want to disable your screen share. Okay. Oh, okay. So I don't see another question, but I have a question. I'm just sort of curious about what were some of the variations in care you saw before, March of 2020, that when you looked at the earlier data that you weren't able to make a comparison.
That's a good question. So some of the variation in care where we saw that some of the patients did not necessarily have invasive strategy despite having MI. And then we also, and I think it corresponded with the era of, I mean, at the very beginning of the pandemic when, patients were not being taken to the cath lab because of the anticipation of the pandemic surge and so forth. And I think that, there was a bit of learning curve there. And, so we saw some of that variation that was depicted, that not all of the patients were undergoing MI evaluation, actually underwent, coronary angiography. But then later on with the pandemic, I think as people became much more comfortable with dealing with patients with MI and COVID that were being taken to the cath lab, and we sort of saw an uptick in terms of diagnostic evaluation with coronary angiography.
Are there any thoughts in following up on terms of looking at a more recent time period to look at whether there's differences still persisting? Did you hear my question? Whether you're going to be looking at more recent data to look at potential changes, right, as the pandemic has changed over time. Are you able to hear me, Dr. Mazimba? So maybe we're having some additional audio issues.
Yeah, so sorry, I think I lost you there for a second. Can you repeat the question if there was any?
The basic question is, you looked at sort of an earlier period of the pandemic right now, as the pandemic has changed. Are there any thoughts of looking at whether the differences are as severe currently as they were in the past, in a more recent time period?
Yeah, I think that's a good question. I would certainly think that, especially with not only the this far out in the pandemic, but also even the effect of vaccine and also just whether there's any differences in outcomes. Certainly, that would be a good question to ask and answer from the data set, especially with the era of various vaccines.
Are there any other questions from panelists today? In the Q&A, I don't see any other questions. So if there are any more questions, we want to thank Dr. Mazimba for speaking, giving a great presentation on the coronary relationship between acute myocardial infarction and COVID negative patients during the pandemic. Thank you for coming today. We appreciate it.
Thank you for the opportunity.
Yeah, and I guess as a group, we'll be back after the Thanksgiving holiday on, I think it's November 28th. So, okay, thank you, everybody. Okay, another question.
Thank you.
Thank you.
Bye.